Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by AGTC, Abbvie, Janssen, MeiraGTx, Novartis, and Roche. We'd also like to thank Accessible Media Inc., our national media partner. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
So this next session, we have two wonderful clinician researchers, Dr. Sylvain Chemtob from Montreal and Dr. Peter Kertes from Toronto. And they are both going to talk about age-related macular degeneration research. So the format of this session will be Dr. Chemtob will give a 15-minute talk, then Dr. Kertes will give a 15-minute talk, and then we'll have time for audience questions. And I heard that the AMD session in the breakout room, there was a rollicking set of questions. I hope you haven't used up all your questions. I'm sure there's going to be more. So as an introduction, to start off with Dr. Chemtob. Dr. Chemtob is a neonatal pharmacologist and physiologist, and he has expertise in the mechanisms implicated in retinopathies and other conditions that involve inflammation, and that includes preterm labor. He holds many positions, including the Canada Research Chair, the Leopoldine Wolf Chair in Translational Vision Research, and he is also a professor of pediatrics and ophthalmology at the University of Montreal, as well as adjunct professor at McGill University. And he is a fellow of the Canadian Academy of Health Sciences and fellow of the Royal Society of Canada. He had a very impressive CV, so that I had to very much shorten it to get through. So I'm going to invite Dr. Chemtob up here, who will give us a short talk on his research.
Well, thank you, everybody. Thank you for the whole audience and the Fighting Blindness Canada, Larissa, Morgan, and Morrison for inviting me, and it's really going to be a pleasure to talk to you about some of our work and some of the future perspectives actually associated with some of this work. So what I'll do for the 15 minutes, I will focus actually on age-related macular degeneration, but of the dry form, and which I'll discuss in a couple of seconds. Then after that, Dr. Peter Kertes will follow me, and actually he'll elaborate quite a bit on the wet form of macular degeneration. So, macular degeneration, what is macular degeneration? I mean, it's a condition, it's a chronic condition, it's progressive disorder of the retina that actually leads to a progressive degeneration of the back of the eye, the area of the eye where actually you have the photoreceptors and the cells that actually support these photoreceptors, which are the cells that actually enable us to detect light and see. Traditionally, macular degeneration has been classified into two different forms, although I really want to point out that they, however, are not mutually exclusive. One form is a progressive degenerative form, which is not associated with a proliferation of the blood vessels, which is seen in the other form, which is the vasoproliferative form of macular degeneration called the wet form. This one actually, its progression could be acute, rapid, and as a result, it could cause its progressive changes may lead to very rapid effects on vision loss. The major macular degeneration is a major disorder worldwide. In fact, when you look at the major markets in the world, United States, China, Western Europe, Japan, it actually afflicts approximately 100 million people in these markets. So worldwide, it's even much more. In Canada, approximately 1.5 to 2 million people are affected by macular degeneration. And as the population, essentially, it's a disorder that approximately 100 years ago was really not very detected. And the reason is because us as humans, longevity has increased quite a bit. And as a result of this increase in longevity over the last century and a half, what happens is that some of our tissues are not actually able to deal completely with these changes, and they go into a process of aging, which is the normal process. So, but normally our lifespan 1 million years ago, 2 million years ago, was probably in the range of about 40, 45 years. And then now we're talking about, with the advancements of the social benefits as well as medicine, we actually have gone into the mid-80s in terms of longevity. And as a result, we live longer, but there are certain complications associated with that, including macular degeneration. So what causes macular degeneration? There's two major aspects that one can look at. There's a genetic component to macular degeneration and a non-genetic environmental component to macular degeneration. And when you look at the genetic component, there is a few mutations that explain a large portion of macular degeneration. And this is actually mutations in a series of pathways that are involved in inflammation and cell destruction called the complement. And then we also have mutations in other areas, which actually I put it at the bottom in here, the ARMS2 pathway, which actually it's not so clear, but it probably is involved in tissue collagen and maintenance of the extracellular tissue in health. But there is other mutations also. And some of these other mutations that participate in this process, in the development of macular degeneration, we have mutations in other inflammatory mediators, such as interleukin. We have mutations in other components of complement. We also have mutation in components of receptors that detect a number of adverse ligands, oxidized ligands, oxidized cholesterol, and it's a scavenger receptor called CD36. And from a point of view of the environmental factor, we have diet, smoking, aging, atherogenesis. They actually, from an epidemiological point of view, they also actually participate hand in hand with the genetic components. So inflammation, however, plays a really when one looks at, dissects out the pathogenesis, the development of the pathology of macular degeneration, inflammation and oxidative stress really stand out very important in this process. Because what does it do? It really actually leads, the inflammation, along with the oxidative stress, leads to a disruption of a number of important molecules in the area where the event is taking place, whether it be these molecules are affected are lipids, they could be actually proteins, they can also be one's own DNA that are affected by this oxidation, and it causes destruction of these important molecules. This leads to a cell damage and even a tissue degeneration as a result of that. So therefore, inflammation, I really want to emphasize, plays a very important role, to the point that one if we want to actually look at what happens over a progression of time, as the cell actually, the macula, which is a region, the region which has the highest concentration of cone photoreceptors in the retina, is bombarded by a high oxygen with time. Because you actually consume so much oxygen, there's a greater chance that because you're consuming oxygen, you're going to generate also these radicals, this oxidative stress. These radicals, the radical molecules, are participate in debris being formed in the retina. These debris then attract inflammatory cells. These inflammatory cells participate in the increase in the size of these debris, and then progressively this inflammation becomes amplified and leads to a destruction of the cells that underlie the photoreceptors, as well as, and if these are affected, then the photoreceptors in turn are going to be affected. So as you can see, as we move towards the right on this schematic diagram that I have shown on there. So then, if we want to actually summarize what's happening, we have this excessive amount of oxidative stress resulting from a number of, from the oxygen that comes from the oxidative components that are developing as a result from these events. Then inflammatory cells are attracted towards these abnormal molecules because some of the lipids themselves are inflammatory mediators. They then attract inflammatory cells to move into the area. The inflammatory cells are further activated. They amplify the inflammation. We go down this pathway. It leads to a disruption of the cells that support the photoreceptors, which is the retinal pigment epithelium, and eventually we have the destruction of these retinal pigment epithelium and what we call a geographic atrophy of this area. Likewise, we can also, some of the inflammatory mediators can generate angiogenic factors, factors that cause proliferation of the endothelial cells. And so the endothelial cells from the choroid start to proliferate aberrantly, and instead of staying below, outside of the retinal pigment epithelia on the outer side, it starts to penetrate the retinal pigment epithelium, which is getting affected, and invades the photoreceptor area, which is completely abnormal. Normally, you do not have vasculature in this area. So, I've talked to you about the process of aging and how this process of aging is associated with inflammation and causes some degeneration of the retinal pigment epithelium and the photoreceptors. But I would like to introduce to you a new concept. And it's something that over the last few years has attracted some attention in the field of maculopathies. And I want to say, I want to point out that my former student, who is now a resident here in Toronto, Ellen Zhao, is the one that had done the initial experiments that led a slew of clinical divisions across the world to publish on this aspect of choroidal thinning in retinopathy of prematurity. And what she pointed in here, she found that it leads to a degeneration of the photoreceptors over time. Now, in other words, what we're dealing in here is a very interesting concept about a pathology which happens in the newborn, especially the premature newborn, where something happens in the choroid, which is no longer able to repair itself, and normally the choroid should be able, And then over time, it actually leads to a degeneration of the RPE and the photoreceptors. And this is what we call adult onset diseases of perinatal origin. So it actually participates in this process. The concept actually generated in the mid-1980s when a famous epidemiologist by the name of David Barker suggested that very early life events can have significant impacts that actually have their onset much later on in life. And he pointed out this between intrauterine growth retardation and hypertension. So now, what she showed is that consistent with this choroidal thinning that is seen in macular degeneration as well as in diabetic retinopathy, it occurs in the choroid. And it actually established a completely new paradigm with regards to retinopathy prematurity. It's not a static disease. It's a progressive disorder that if we actually continue to follow these patients, we actually see that there are actually degenerative changes. However, so far, our patients, premature infants that are adults and there's sufficient numbers, are only in the range of about 30 years old. And the only reason I'm saying that is because as a neonatologist, what really made a difference is actually the advent of actually surfactant to maintain them alive. So actually, what we're seeing right now in some of the early studies is actually that there is a gradual degeneration of the retina in these patients. Oops. Oh, sorry about that. I'm going to actually, well, very quickly. So far, in terms of macular degeneration, we really have very little, especially specifically the dry form, we have very little to offer. Some antioxidant molecules, some vitamins that affect actually the oxidative process, have been thought to maybe have an effect, but in fact, it's really a very marginal effect that is seen by that. And when you look at however, what's being developed right now, there is a potential for very promising new agents. Many of them are involved in complement. Unfortunately, very quickly, I want to say, this is not turning out to be extremely effective. It has some effect, but not extremely effective. So therefore, new, solutions are being sought. In this process, I've talked a lot about inflammation. So we tackle actually complement. But one of the aspects that would be very interesting to tackle is actually the inflammatory mediators directly themselves other than complement that actually play a role more downstream of complement in the process of degeneration. And I think that some of the early studies seem to suggest preclinically that this actually could be and in fact, there is two companies that have actually emerged looking at these aspects in the United States, and we are ourselves interested in moving along these lines with new compounds. And another, oops, sorry about that. Another component is something that we're working on, which is CD36. And I told you that a mutation in CD36 can actually predispose to macular degeneration. CD36 is a scavenger receptor. It is actually present on all of the cells that are actually in the subretina, the pigment epithelium, the choroidal endothelium, the microglia, and the macrophages. Moreover, it's a multi-ligand receptor. In other words, it is affected by different oxidative components of the cell to stimulate it. And finally, it's actually new molecules are now being derived to be able to modulate the activity of this receptor and resulting in actually an attenuation in the progressive degeneration associated with it. So therefore, this is a summary of actually the different properties of this interesting receptor, CD36. It's antioxidative, it's anti-inflammatory, it modulates actually a lot of aspects related to macular degeneration, including the thickening of the Brooks membrane, and also it protects the retinal pigment epithelium. So with this, I'm sure there's going to be a lot of different questions related to the future perspectives, and I leave the micro to our colleague Peter Kertes. Thank you so much.
So Dr. Kertes majored in molecular biology at Princeton University and went to McGill for medical school. He undertook a 2-year vitreoretinal surgical fellowship at Louisa State University and has been in practice first in Ottawa and now at Sunnybrook Health Science Center. He is currently a professor of ophthalmology and vision scientist, and from 2010 to 2021 acted as the ophthalmologist-in-chief at the John and Liz Torrey Eye Center at Sunnybrook. Dr. Kertes has an interest in clinical epidemiology and a special interest in international ophthalmology, and has participated in 25 volunteer projects throughout the developing world, many of them focused on retinopathy of prematurity and pediatric retina. So welcome, Dr. Kertes.
Thank you. So I'm going to, unlike Dr. Chemtob, who talked about dry macular degeneration, I'm going to talk about what we commonly refer to as wet macular degeneration. I'm just going to take a step back, and I apologize to those of you who are well aware of this, and but just to take you through the progression. So when we talk about the macula, so we'll start with simple anatomy. We're talking about the part of the retina. The retina lines the back surface of the eye and works like the film in a camera. It's responsible for interpreting what's out there and sending it back to your brain as vision. And most of the macular degeneration demographic understands what film in a camera is. When I make that analogy to a younger demographic, they look at me like, film, like what's film? But I think most of you probably remember the days when cameras had film. So it's like the film in a camera, and the macula is the very center part of the retina. It's the part of the retina that's responsible for your reading vision, your color vision, your driving vision, all the things, all the detail vision that we need to do the things that we like to do and need to do. And when we talk about wet macular degeneration, often the terms wet or neovascular are kind of used synonymously. And what happens in the context of wet macular degeneration is you get these abnormal blood vessels, and they have a tendency to favor that central part of the retina, the macula. And they grow under the retina, and they leak fluid, and they bleed, and they cause all manners of difficulties. People have distortion, they lose their central vision, and they lose that ability to read easily and to drive and see colors the way they normally did. And this actually represents a smaller fraction of the macular degeneration population than the dry form of macular degeneration. But it's responsible for the more rapid and more severe losses of vision. So, today's talk, I was going to focus on what's coming in macular degeneration. By and large, wet macular degeneration is treated with injections. So we target a molecule called VEGF. The acronym is VEGF, VEGF, and that stands for vascular endothelial growth factor. And we know that that's a molecule that the body makes that promotes the growth of abnormal blood vessels. It promotes their growth, and it promotes their leakage. So we inject things into the eye, different medicines into the eye, that block the action of VEGF and stop those blood vessels from growing and stop them from leaking. So VEGF has been our target, has been the bad guy, was on our most wanted list for, since these agents came out, which was, they first became clinically available to us in 2006. So we've been at this for a little while, but now we're starting to look at newer targets. And I've kind of divided this talk into 3 stages. I divide, the first one is like what's coming soon. And in scientific terms, when we say soon, we don't mean tomorrow. We mean sort of in the next 5 years. And then there's sort of the intermediate group. So there's some agents that are coming along that will probably be in our hands and in our clinical practice kind of in the 5 to 10 year range. And then there are the more sort of pie in the sky things that, like the holy grails of ophthalmology, that are kind of in the longer term. So those are sort of in the 10 plus year time frame. So what's coming soon, and actually, some of these agents are actually already here. They're here, they're available, they're approved, but they're not yet reimbursed. So it's really when the government agrees to pay for these things that they get into widespread usage, because a lot of these agents are pretty expensive and not widely available. But we started to look at different targets. We know that this vascular endothelial growth factor is a primary mover and a primary culprit in the setting of wet macular degeneration. But there are other targets. There's a molecule called angiopoietin, and there's a new drug called faricimab, which targets not only vascular endothelial growth factor, but it targets angiopoietin too. And we know that it too is important in the growth of abnormal blood vessels and the leakage of abnormal blood vessels. And this molecule, faricimab, which is approved, but not yet reimbursed, targets not just VEGF, but it targets angiopoietin. And that has, and we're pretty excited about, we have some people that are on it, but we're pretty excited to see how this is gonna play out in our clinics. And I think, the biggest impact it will have is that we'll probably be able to stretch out the injections. So, there are many people with macular degeneration, or I know this is a macular degeneration talk, but we use it in diabetic macular edema and people with, blockages in the veins in the back of the eye. We use it for a number of different things. Many of these people, do well with treatment, but they need frequent treatment. These medicines don't last very long. And there's some people that need injections as often as every month. So our hope is with these new agents that we'll be able to stretch that out, and we'll get more and more people that, if not every 4 months, and every 3 months, or every 2 months. So that's here, and I think we'll see more and more use of those things. And there are other targets that are in clinical development that I think may help kind of tweak our treatment of macular degeneration. We also have different platforms. So, it's very difficult for our patients and for our caregivers to come as frequently as may be in, as may be in their best interest. We have this thing called winter in Canada, and many of our, many retina specialists are kind of concentrated in the big cities, and many people live far away from those big cities, and they have to travel. They often have to rely on a family member or a caregiver to bring them in, and sometimes, especially in the winter, that can be challenging. And some people like to escape the winter. So for them to come every month when they're in Florida for 3 months can be impractical. So I think the hope with these agents is that we can go longer and longer. And there's some platforms as well. So there are these things called hydrogels, and there are these things called antibody conjugates. So these are, basically, they're clear, and they're kind of globs of stuff that we put medicine into. And the hope is that we can put medicine into these globs that we also inject into the eye, but that they can be released more slowly into the vitreous, so that that might give them a little bit more longevity. And another thing which offers us a little more time and a little more leeway are these things called port delivery systems. So there's a very ingenious device that has been developed, which is implanted surgically. So you need to go to the operating room to implant this device. But it's like this little pod that we put into the eye. We sew it into the eye, and it's filled with these medicines, these anti-VEGF medicines, and they're slowly released into the eye over a period of time. And they can be refilled. The device is implanted in the operating room, but the refills can be done in an ophthalmologist's office. And for the most part, many people can go as long as 6 months between needing a refill of these agents. So there's some issues, of course. It has to be done in the operating room. And whenever you operate on an eye, as opposed to giving a simple injection or a drop even, the risks and the complications are significantly greater. Although it can be done safely, and it's almost always done without complications, there are significant complications that can occur. And we in Canada have, somewhat limited access to the operating room, and there are lots of people with wet macular degeneration, so I think it remains to be seen what the uptake of these things are. But that too is an option. These little ports, these little reservoirs of anti-VEGF medicine. So these are things that are sort of imminent. When we talk sort of in the medium term, in the 5 to 10 year time frame, so I'm sure for those of you that were here in the morning, many of you probably have been here for the better part of the day. I'm sure you heard lots of talk about gene therapy. And we have a gene therapy that I expect many of you are aware that has been approved, and that, it's been tremendously exciting for people with retinal degenerations. But we have gene therapies that I think will be coming before too long, not for retinal degenerations, but for macular degeneration. And the idea is a little bit different. With retinal degenerations, the gene therapy delivers something. If someone has a mutation in one of the vital molecules that is important for vision in the back of the eye, you can either correct that mutation, or you can add the correct gene into the cells that are important, in which that mutation lies. And that's tremendous. But you can also put genes into the eye that are like these factories. They're like biological factories that produce these agents like aflibercept or ranibizumab, things we inject commonly into the eye. So this too is can be delivered in one of two ways. There's a company called Regenex Bio that has a product that's injected under the retina with surgery. So again, all the attendant risks of surgery are there, but you've created this factory, this drug-making factory in the back of your eye, so that hopefully you won't need any injections going forward. There's another company called Abbvie, in which this gene therapy is injected into the vitreous. So it's just like your injections for wet macular degeneration. This is a product that's injected into the vitreous and hopefully is taken up and produces and creates this bio factory in the eye. There have been some issues and some concerns about inflammation. All these things, there's no, other than at a meeting like this, there's no free lunch. There's always some upside and some downside. So, these are things that are in clinical trials. We're a clinical trial site for the Regenex Bio trial for macular degeneration, and we're very excited to see what comes of this. I think this will be a real option for many people. And Dr. Chemtob talked about dry macular degeneration. So, there's a significant overlap between dry and wet macular degeneration. So what happens in dry macular degeneration is you get these wear and tear changes. And many people over time, many wet macular degeneration patients, do very well in the short term, but with ongoing injections and over time, they develop kind of dry macular degeneration changes. So there, I think in the not too distant future, we'll see some marrying of both dry macular degeneration treatments and wet macular degeneration. So hopefully we can limit those wear and tear changes. And then in the long term, there are things like there are cell-based therapies. I think there are ways of there will be ways, I think, of transplanting the retina, or even more importantly, the retinal pigment epithelium, which is the layer underneath the retina that supports and nourishes the retina. And there'll be some marriage, I think, too, of these gene therapies with RP transplantation. So we'll be able to put new, healthy RP cells under the retina that will produce these drugs that will limit the growth of these abnormal blood vessels. And of course, the holy grail of ophthalmology is stem cell therapy. I know Brian Balios, I'm sure, spoke very eloquently about stem cell therapy for those of you that were able to hear it. And I think, that's the most exciting thing, not just for ophthalmology, but for all kinds of areas. And I certainly hope we see that in all of our lifetimes. But I think that's a little bit that's a little bit in the more distant future. So I know Dr. Chemtob and I will be more than happy to answer any questions you might have.
Okay, so we are going to have questions from the audience. Is there a... Okay. Yeah. Jack is going to come around with the microphone, and we'll start with questions.
Okay. My question is, you mentioned about inflammation. Could you use drugs that are used for anti-inflammatory use? Could that be used for macular degeneration?
Yeah, this is a very, very good question. When you look at traditionally the old term non-steroidal anti-inflammatory agents versus, I'm going to start with that, non-steroidal anti-inflammatory agents, the effect is rather modest in terms of inflammation, and the results, therefore, are modest. Corticosteroids are used in the case of macular degeneration, but corticosteroids have, we've known in medicine for a long time, they are associated with some adverse effects. And so to address your question specifically, yes, there are now a number of molecules which are actually either recombinant proteins or antibodies to specific inflammatory agents, and these could be. The problem with some of these molecules is that two things. One is actually that their accessibility to areas of significant damage sometimes is limited. The other thing is actually that they are also they also can have adverse events. So therefore, so one of the issues that that is being addressed right now is not only actually to take these large antibodies or recombinant proteins that would actually interfere with the action of the inflammatory agent, but actually developing agents that can modulate the activity of the inflammatory receptors in order for it to be suppressed, but actually without actually leading to absence of immune vigilance and cytoprotection. So this is an area that is quite a bit ongoing in the area of pharmaceuticals, what we call allosteric modulation of receptors. I hope I answered your question.
Thank you for answering my question.
Any other questions?
Yep. Oh. I've got a question for both doctors. I don't know if I misinterpreted this, Dr. Chemtob, but I thought I heard you say that macular degeneration could be an expression of something that happened in early life. And does that only apply to dry or to dry and to wet? And then the second part of that question is, would that explain the incidence of macular degeneration where there doesn't appear to be a genetic cause?
So this concept actually of adult onset diseases of perinatal origin as it applies to macular degeneration is something actually that is only starting to be demonstrated. So far, what we know clinically in here is that there is a number of patients with the most severe type of RO, retinopathy of prematurity, that when they followed actually later on in life, they actually demonstrate, in fact, early life, they don't demonstrate it so much, but if you continue to follow them, as they are late adolescents, early young adults, they start to demonstrate actually dysfunctions of the photoreceptor functions on electroretinogram. Some of them actually even, and it's been reported by groups in Korea. They've even actually shown some degenerative changes of the RPE, of the retinal pigment epithelium. Whether actually, to address your question, whether actually this could explain the genetic component, so this has not actually been specifically addressed so far. It's really an early concept that is coming out, and it's really pretty much in line with a lot of this whole concept about adult onset diseases of perinatal origin applying to hypertension, atherosclerosis, diabetes, stroke, and also, and now affecting other tissues. There is even in dementia as well, and now in macular related to maculopathies.
Just a quick question. When gene therapy is finally available, how will it be applied? Is it going to be a needle in your eye, or medicine, or you drink or take something? How will it be applied to you?
Yeah, I mean, I think the gene therapies for macular degeneration that we will see the first, that we will see the soonest. There are two competing companies. One is it's delivered at the time of surgery. So an operation called a vitrectomy is done, and the gene therapy is injected into the space, the potential space under the retina, and is done that way. There's another gene therapy product that's injected into the eye. It's done by injection, and so the hope is with the first one, the one that's done in the operating room, is that it'll be a one and done kind of thing. You'll have the one surgery and you won't need any injections going forward. Or if you do, you'll need very few injections going forward. The one that's an injection into the eye, you'll probably need those injections more often. You'll almost certainly need more than one. You'll need them on an ongoing basis. And because they tend to be a little bit more inflammatory, you'll need to kind of cover that with some anti-inflammatory type medicines. But the jury's still out on those things. But so they're two different. Often one one methodology kind of emerges as being better. So we're not that far yet.
Any questions?
We've got time for a couple more.
One right here.
Now, are you aware of any medications being developed either for dry or wet AMD that are going to be delivered in the form of a drop?
Yeah. So in the list actually of the different compounds that are actually being generated, the great majority are actually intravitreally. Some of them there's a couple of them orally, and there is one actually that was actually suggested by drop. Macular, which is really a very old, is a company which is a very, very old drug, initially had actually some positive response. The compound is called hydralazine. It's a drug that exists for about 60 years already. It's been refurbished. But unfortunately, in a follow-up trial, it didn't pan out. So the company actually, right now, when we look at clinicaltrials.net, we actually, there's a stoppage of activity of this compound. But I think that Peter will agree that one of the technologies that would be fantastic to develop in terms of formulation is a formulation that enables actually a drug to penetrate across the globe.
Yeah, I mean, it would certainly be much easier to deliver a drug by, topically with a drop. And there have been some, and we've participated in clinical trials looking at agents that are given topically, but they just don't make it to the back of the eye in sufficient quantities to have a beneficial effect. But most really, at conferences and things, nobody really talks about a topical agent for macular degeneration. I think, it'd be great if we had a delivery system that was simpler, but we don't yet.
Okay, last question.
I have two questions. The first is my ophthalmologist. I have dry macular, and he said there's no treatment, as you have said. But if it crosses over to wet, you seem to have different treatments. So does it cross over to wet and you have treatments that make it better, or is it equally bad?
I mean, it's true, but all wet macular degeneration starts out as dry macular degeneration, and the dry form tends to be less severe. That's not always true, but it's mostly true. So usually when you've transformed from dry to wet, you've had some progression, you've had some loss in your vision or some new symptoms, which is the bad news. But the good news is we do have pretty good treatments for that that can control the growth of those abnormal blood vessels. So I'm not sure if I'm answering your question. There is a treatment coming for dry macular degeneration. I think that'll be sort of, maybe late next year. It too is an injection into the eye, as Dr. Chemtob so eloquently described it. It blocks one element of the inflammatory pathway, and it seems to have a beneficial effect. So it's not, it's not going to be, an earth-shattering effect. It's mostly a drug that will slow the progression of dry macular degeneration. But at the present time, we don't have a treatment for dry macular degeneration.
Okay, thank you. The second question is, according to my ophthalmologist, when I told him I smoked from the time I was 14 till 30, he felt that was a big contributory factor to having macular. Is that the same parallel that we're seeing now, that drinking too much is causing cancer and that it's finally being acknowledged?
I'm sorry, this question was about smoking?
Yes.
Yeah, I mean, smoking is the only controllable risk factor we know for macular degeneration. Our understanding, and as a scientist, probably Dr. Chemtob has a much clearer understanding of this, but as I think a good way to think about it is it creates oxidative stress. So you get this release of all these kind of toxic compounds as a consequence of smoking, and depending on what tissue it's invading, one can lead to the production of cancer, and in macular degeneration, it can lead to the production of these abnormal blood vessels, or accelerated wear and tear changes in the back of your eye.
So I was going to say that was the last question, but Morgan, who's the next host, has just walked out of the room. So there might be time if anybody has a short question. One more.
Doctors, I'm just wondering, is AMD or MD more prone in some races than in others?
Yeah, absolutely. It's much more common in Caucasians than non-Caucasian.
And do they know why?
Yeah, I mean, there have been a number of mutations, a number of genetic mutations that have been linked to macular degeneration, and they're more common in different populations.
Thank you.
Yeah, we might as well take a few more questions. Yeah.
Am I correct that most of the treatments for wet AMD right now are preventing the advancement of the condition versus actually improving the vision, and stem cell is the only thing that will improve the vision?
Yeah, no, when we embark on treatment for macular degeneration, we expect people's vision to improve. And most, and on average, it does improve, and a significant amount. I mean, it never comes back to normal, but it almost always gets better. And I'm sure different people in the room have different experiences, but typically we do an injection every month for usually 3 injections, and most practitioners will try and stretch it out after that. But you do plateau, and then on an ongoing basis, our hope and our expectation is that we stop you from losing vision. So there is an initial bump in your vision. Like we don't expect you improve and improve and improve indefinitely. You sort of, the curve goes up, your vision gets better, and then we try, the goal is to maintain you at that higher level of vision, but not as high as it was before you had this problem.
Okay, really the last question now. There we go.
I understand that, I think you briefly mentioned alcohol is not good for AMD. I'm wondering how much, is there a limit? Or what can one safely drink?
Yeah. Yeah. I mean, there are recommendations about what is a reasonable, what is a potentially beneficial amount to drink and a bad amount to drink. But in the setting of macular degeneration, alcohol has never emerged as a risk factor. So I'm just talking about the eye. I'm sure other physicians, have clearer answers, but as far as your, unless you're drinking methanol, it should have no impact on your eyes. Don't be drinking that stuff in the bathtub, though.
Okay, I think we ended on the most important question. So I want to thank Dr. Kertes and Dr. Chemtob.